Hello everyone, my name is Kristin Magner and I'm a pediatric nurse practitioner at Children's Wisconsin. I am presenting to you today under the category of Best Research Award. And I'm going to take a little bit of an unconventional approach today and talk to you about two of my research and projects involving dexmedetomidine and how my start with an oncology quality improvement project led to my future opportunities. So dexmedetomidine, the two populations we're going to talk about are non-invasive ventilation and sedated apheresis, both of these in the pediatric population. And then how to grow a research or a QI focus, or at least how this has progressed for me with successes, failures, along with data collection and dissemination. I do not have any financial disclosures. So starting with dexmedetomidine, what is this? Well, we love this in critical care because it provides sedation, decreases sympathetic overflow, provides opioid effects as an analgesic, minimizes delirium, provides sedative properties with minimized respiratory effects, although you may see lower heart rate or blood pressure, especially in the lower age groups. It's more selective to alpha-2 than clonidine, and that's the enteral formulation of dexmedetomidine, and what is used outside of the operating room or the PICU. So dexmedetomidine to provide sedation with minimized respiratory depression. We use this on multiple occasions in the PICU. Some examples: post-op cardiac catheterization, echocardiogram, apheresis, procedural sedation, in patients that are intubated and maintaining their natural airways, and of course, non-invasive ventilation. So this picture here presents some mask options we use in the PICU while a patient is receiving non-invasive ventilation. So if they wore any of these mask types, would they need sedation with dexmedetomidine, or would you feed the child? So let's go over the options. Here in the upper left-hand corner is a high-flow nasal cannula or RAM cannula. Then down below, nasal prongs. In the middle, an oral nasal mask. Up to the right is a full-face mask, and below, a nasal mask. And if you pick, let's feed the child, which route would you feed them by? Would you feed them by their mouth? Would you put an NG tube that goes from their nares to their stomach, or bypass the stomach and go into the jejunum and feed them via an NJ? A G tube that goes right into their stomach, or a GJ tube, which you could feed either via the gastric or jejunum. And so we have a national study that I am currently involved in to study the association of enteral nutrition and dexmedetomidine use in critically ill children requiring non-invasive ventilation, with the short title NIV Dex EN for enteral nutrition. So background, there is growing safety and efficacy, growing evidence of this for enteral nutrition during non-invasive ventilation in the PICU. And there's also growing evidence of safety and efficacy for dexmedetomidine as the primary sedative agent of choice to improve the tolerance of non-invasive ventilation in children. So the Pencis Network is a national organization and stands for Pediatric Acute Lung Injury and Sepsis Investigators. Pencis conducts research in many areas with the common goal of improving pediatric critical care. Within Pencis, there's subgroups, one of them being Nutrinet, or the Nutrition Network, which I'm a member. The NPO-NIV study is an international multi-site study from the Nutrinet group, which enrolled 830 children across 59 sites. Although this is not yet published, it was found that children fed on the first day of receiving non-invasive ventilation required sedation only 13.7% of the time, although if they were not fed, they required sedation more than 40% of the time. So when and how should we feed kids with non-invasive ventilation? And if this shows that being fed decreases the need for sedation, why not feed all of our kids? And so we developed this study to gain a little bit more information. The time frame for this study was pre-pandemic, which is why enrollment ends at the specific date, because everyone wants to reflect a little more of a pre-pandemic state. So it's from April 1st, 2019 through March 31st, 2020, a retrospective cohort study with inclusion if you're 0 to 18 years of age, admitted to the PICU, and supported with non-invasive ventilation for at least 12 hours. The exclusion criteria is if you already have non-invasive ventilation at home, you are already on dexmedetomidine before needing non-invasive ventilation, or where you're using additional sedation to facilitate the tolerance. So what kind of support did we use? High flow nasal cannula if you met a specific criteria, CPAP, BiPAP, NAVA, or any other form of non-invasive ventilation. The parent study is housed at the University of Florida, and it is a multi-site study with 15 sites enrolling patients. It is exempt study with each site having individual site IRBs. And how we enter data is we enter the data into a REDCap database. And REDCap stands for Research Electronic Data Capture and is a secure web application to manage online databases, and it is used by researchers from multiple sites and institutions. So this is how, when we enter the data, it'll ask for which day you are entering the data, and then initially you provide all of the demographic information about the patient. And how did I find the data on each of these patients? We used a VPS database. This is the largest international database for critically ill children. Our PICU is a part of this, and this includes comprehensive information on pediatric PICU admissions. The data that I was able to obtain from VPS includes all of their demographic information, their primary diagnosis, the PLOD score, which is a pediatric logistic organ dysfunction score, or describes their pre-existing severity of illness. And then we needed to do a chart review to search for what kinds of type of mask did they have while they were on non-invasive ventilation. Were we using dexmedetomidine? What type of formula and route of feeds did they receive? And all of the calories of the formula and the specific details of dexmedetomidine, including the amount of hours, the total amount, so that in this way we obtained the nutrition information and the sedation information, as well as the type of mask while on non-invasive ventilation. So we alone from our institution have entered 278 patients, and there's a total of 1,470 patients entered through all databases. Thus far, we have found an inverse correlation between feeding and sedation. What mask, what route of feeding, all of that is still, the data is in process, as well as what typical doses of dexmedetomidine we're using for sedation. So with the results still pending and the data cleaning and analysis is currently in process, we did propose 2 ancillary studies that were approved as part of the study before data collection began. So ancillary studies, these are independent research projects that use samples or data from a parent study to extend the knowledge in a scientific area beyond the original scope of the parent study. Our studies are the Association of Enteral Nutrition and Dexmedetomidine dose requirements for term infants and premature infants who require non-invasive ventilation. And the second is the association between enteral nutrition and dexmedetomidine usage of neutropenic children, including those with mucositis who require non-invasive ventilation. And how this data collection was addended is that on the demographic page, after we collected the age of the child, then if their age was 0 to 12 months, then it would also give those entering the data into REDCap an option for prematurity. And if you said yes, no, then if yes, it would also ask for what your gestational age was. And then under neutropenia, it would ask, was the child neutropenic? If yes, then also does he have mucositis? And all the sites are entering in this data for our future study. And upon completion of the data entry, there's a data transfer agreement in place, and this will transfer to Medical College of Wisconsin. So this is the conclusion of my first project. But how did I get here, especially as a nurse practitioner? We have different academic and administrative responsibilities within our role and may have opportunities to volunteer or unvoluntold on different projects. So I was given the opportunity to lead a quality improvement project to improve sedated apheresis in the PICU. And I'm going to tell you a little bit about this starting point and really my plug for getting involved in different projects, because we learn a lot along the way, and it may lead for additional future opportunities and future research opportunities. And my current interest in dexmedetomidine and sedation started with this quality improvement project that we completed using dexmedetomidine for sedation during sedated apheresis. And this I will tell you a little bit about. Apheresis. It's a procedure in which whole blood is removed from a patient by an apheresis machine. As part of the blood, such as leukocytes or stem cells, are separated and the remaining blood is returned to the patient. The white cells or stem cells are later used to treat certain illnesses, mostly in the BMT or oncology populations. Oftentimes, the apheresis procedure is done without sedation and the PICU is not needed. However, high-risk patients that have anxiety, young age, or can't sit still for the hours it takes to allow for good interface between the patient's line and the machine need sedation and a PICU admission. So sedated apheresis. What problems did we find in order to need a quality improvement project? One, some patients admitted to the PICU weren't getting any sedation, even though that may have been the initial plan. There were all sorts of different sedation types that were being used by providers. The plan was uncertain of sedation or how long sedation or what type, and there was prolonging cell collection with some of these uncertainties. So our goal is to improve sedated apheresis in the PICU. So this was really a collaborative effort. We developed a guideline to identify patients who were high risk and needed sedation in the PICU. In short, to determine who needed a central venous line in IR, and then how we would start dexmedetomidine either for the Mahuka placement or upon admission to the PICU and continue until the cell collection completed. So walking through this guideline, on this slide, we identified them as high risk. Yes. Do they have a line? Yes. Then they go directly to the PICU. No, they go to interventional radiology. There they start dexmedetomidine, place the catheter, continue dexmedetomidine, they're admitted to the unit, and then already sedated, and dexmedetomidine continues until collection complete. So clinical success, that's what we started to find once we implemented the guideline of using dexmedetomidine. So we decided, let's track some data and figure out what we find. But I really kind of stumbled through the process because, well, what do I collect, and maybe times, and then after the fact I would go back and look for the demographic information. We did the proper steps and obtained IRB process, but we didn't have a REDCap to collect all the data as I currently am in my national project. So I really learned a lot, not having a formal database and not having a specific procedure to collect the data, and making a lot of mistakes along the way. So what did we find? We compared the demographic and the clinical characteristics of the patients, and we found that there was no difference in their gender, their age, or the weight in the group of patients prior to the guideline and after guideline administration. Intervals of time. Intervals of time were quite a bit shorter post-guideline. The time from PICU admission to start of sedation was statistically significant. The time from PICU admission to start of apheresis was also statistically significant, as well as the time from the PICU admission to the end of apheresis. Our other times were clinically significant in the total time that the patient would spend in the PICU, the total apheresis time, and the total sedation time. We also compared the medication, the doses, and their disposition. And we did not find any specific difference in the medications or their doses. However, there was close to a statistically significant improvement in patients that would go home directly from the PICU once the guideline was implemented. So here's a PICU length of stay pre-guideline versus post-guideline. And so we thought, oh, well, maybe we should disseminate some of this information, which is in part what we're doing today, and have presented at Pediatric Oncocritical Care Symposium, the Society of Critical Care Medicine, manuscript in transfusion and apheresis, and I am thrilled and happy to be presenting with you today. So in conclusion, if admitted to the PICU for apheresis, start sedation with dexmedetomidine. Is dexmedetomidine better than propofol or other sedation? This isn't a randomized control trial, so we don't know. However, we do know that when you follow the guideline for sedation, this was a quicker and more efficient process. And we published our guideline on our hospital's Connect website, so it is easily available. So we finished one project and we're in the middle of the next project, which is what I currently talked to you about at the start of this presentation. I have completed entry into REDCap, and we're in the process of data cleaning and data audits. So as we wait for the data cleaning, analysis, and data transfer for our ancillary studies, maybe we want to start another project and decide to compare dexmedetomidine to propofol for procedural sedation. How would we go about this? We pick a population or a procedure, we assemble a team, design the project, meet with a statistician. Then now, from learning from prior experience, we build a REDCap database to house all our data. After we've obtained IRB approval, collect the data, analyze, disseminate this information. And with research, it does take a lot of time and support, and we really need this support from our families and colleagues, especially as this whole process may seem scary. Although this picture of children are just my own children in their Halloween costumes, so don't be scared. Get involved in a project. We learn a lot along the way. And I really want to thank all of my mentors for their support of me and this research project. And I hope I've been able to provide a little bit of information to you of the research process and my journey along the way. Thank you very much.